Hi, welcome to my ABA oral examination sample questions. In this session, we will discuss this intra-op post-op case, which is, as you can see, a 55-year-old, 52-kilogram woman brought to the operating room for an urgent X-lab for a small bowel obstruction. It is a bit colorful because I just was trying to play with the colors in this slide. So you will have about 10 minutes to go through this case, and then you will go in the room and answer the intra-op and sorry the yeah intra-op and the post-op questions. The intra-op questions would last for like 10 minutes, and the post-op questions would last for 15 minutes. So I will spend about 10 minutes on scanning this question and see what if I have this question actually in my test, what I would think during the preparation period before I go in, what kind of points I would be highlighting, and what kind of questions would I prepare mentally. So I will think loud. I will talk through what I'm thinking. So this is an urgent case that is a small bowel obstruction. So it is an urgent case. It is not an emergent case, as we can see. And then you have 2 days history of small bowel obstruction, and as we see that probably it's because of adhesions. Patient could be dehydrated because of small bowel obstruction. Then under meds, patient takes stitch. That's probably because of atrial fibrillation. Lasix probably because of heart failure, and then KCL because of Lasix. Then in the past medical history, there are some important clues such as mitral stenosis with a limited exercise tolerance. That means it's a moderate to severe mitral stenosis. Then this mitral stenosis has also caused or given this patient a pulmonary edema and AFib. So this patient would have left atrial dilation, and then it's a severe enough mitral stenosis to affect the left atria and the pulmonary circulation, and possibly the right ventricle. Now the next hint is that this patient tolerated the general anesthesia for colectomy 2 years ago, so it doesn't have any funny malignant hyperthermia or allergies, or maybe no airway issues. I would say maybe because it doesn't specifically mention the airway. However, general anesthetic without difficulty means most likely they did not have any airway issues. I always make a point of asking myself about airway again and again in this test because airway is something we deal with every day, and can mismanagement of the airway can kill the patient not only in the test but also in the real life. Now looking at the physical examination, I see tachycardia and I see hypotension, and respiratory rate is 30 and temperature is more than 38 degrees. So if you look at these vitals, they suggest that this patient has a systemic inflammatory response syndrome. Um, tachypnea, hypotension, febrile or pyrexia, and also tachycardia and tachypnea, if I didn't mention that. In the examination, as we see that this patient has ischemic dyspneic crossly distended abdomen, airway appears adequate for intubation. So this is important here because I would just do general anesthesia with endotracheal intubation and use RSI. There's no pressing indication for awake fiber optic. Lungs show basilar rails bilaterally, so patient does have a pulmonary edema clinically. And then 1+ pitting edema that shows right heart failure. Chest X-ray shows right ventricular prominence, increased pulmonary vascular markings. Again, an evidence of right heart failure. Then EKG shows atrial fibrillation. Scanning the labs, it shows a hemoglobin of 10.5, sodium 132, so hyponatremia, slight anemia, hypokalemia, maybe because of Lasix, maybe because of vomiting too. ABG shows hypoxia, and PaCO2 is lower end of the normal, pH is normal. So this means that this patient does have a pulmonary edema and maybe pneumonia, but most likely a pulmonary edema. I would go with pulmonary edema, not pneumonia, because chest X-ray does not show consolidation in this scenario. On arrival to the operating room, the patient has 18 gauge peripheral IV and a right IJ double lumen CVP catheter in place. Okay, so we are in the operating room now, and this is what we have. So summarizing this case, I have urgent surgery, few hours to optimize this patient, a septic patient, source of sepsis is the abdomen, and patient also has a superimposed mitral stenosis, moderate to severe aortic stenosis, and this will cause some problems as well. What I have until now is an IV access and a central line, so I have to do rest of the things for this patient. Okay, so we will first go through the questions as in an oral exam format, that is 10 minutes timed exercise. After that 10 minutes timed exercise, we'll shift to the next one, that is post-op 15 minutes timed exercise. And end of 25 minutes, we will do the 3 grab and go cases, and then that would be about 40 minutes, 35 minutes, 40 minutes, and after that we will analyze about what we did, how I did, and critique. Okay. Okay, so what we have here is now the question answers for this particular case, and we can start answering the questions and answers. Let me so let's do intraoperative management part, 10 minutes. You are unable to establish the left or right radial artery catheter. Is the blood pressure cuff adequate? Given that this patient is moderate to severe aortic stenosis with pulmonary involvement and pulmonary edema and heart failure, and this patient is septic and dehydrated, I want to watch this patient's blood pressure very carefully, and because there's a risk of significant hypotension both during induction and in an intraoperative period. And also this surgery can involve a major blood losses and third space losses. So blood pressure cuff is itself not adequate. Okay, so what would you do if you can't obtain an arterial access in left or right radial? At this point, my options are I can use ultrasound to locate the right or left radial and use ultrasound to obtain an access. If that's not possible, then I will try to obtain a arterial line in right or left brachial artery. If that's not possible, then I would try to do it in the femora, and I will use ultrasound to locate the artery. It's important to get an arterial line in this patient, ideally pre-induction. Okay, so you cannot get a arterial line pre-induction in this patient because patient is crying in pain and patient doesn't want you to put a line when patient is awake. What would you do? In this case, I will explain the dangers of not obtaining a arterial line pre-induction to the patient. However, if patient constantly refuses, then I will cycle my blood pressure cuff to every 2 minutes and induce with all the precautions, and then try to obtain an arterial line post-induction. Okay, would you change the CVP to PA catheter prior to induction of anesthesia? Yes. PA catheter would give me additional information such as cardiac output, systemic vascular resistance, pulmonary vascular resistance, and also the information that CVP can give me, that is right atrial pressures. I will put a Cordis, and then to the Cordis I will put a PA catheter. So this would give me a large bore IV access as well as a PA catheter. So patient is unable to lie flat, and it's unclear from the waveform that PA catheter is in wedged position. How would you determine? So the trace of the PA catheter shows systolic pressure and then a diastolic pressure if PA catheter is in the right place. And wedging would give a left atrial pressure, that is pulmonary capillary wedge pressure. First of all, I'll withdraw the catheter, and when I see the right ventricular trace, that's a right ventricular systolic pressure with very low diastolic pressure, which is typical of the right ventricle. I would advance the catheter slowly. Once I get an elevation of the diastolic pressure and a change in the shape of the waveform, that means I'm in the pulmonary artery. That is the right position. Then I will try to wedge the PA catheter. Okay. So blood gas from the PA catheter, is it useful to see if PA catheter is in the right place? Blood gas would not, this is a mixed venous blood gas. It would not actually give me a whole lot of idea about if PA catheter is exactly in a branch of a pulmonary artery, because the readings would be same as if I take a blood from the right ventricle, will be very similar if I take a blood from the right ventricle or from the right atrium or from the pulmonary artery branch. What are the problems associated with current potassium level then in this patient? The potassium level is 2.8. It's low, and this can lead to cardiac arrhythmias. So I want to correct this potassium level and bring it to the normal level of 3.8 to 4.0 with intravenous potassium. Okay, would you use thoracic epidural in this patient? I would not put an epidural in this patient because of number one, patient is septic and maybe possibly bacteremic, and this can lead to introduction of infection in the epidural or intrathecal space. Secondly, this patient cannot tolerate decrease in afterload, which can happen with thoracic epidural. And thirdly, this patient already is hypotensive and dehydrated, and any further reduction in afterload with peripheral vasodilation can be dangerous. Okay, is awake intubation appropriate? This patient does not have a difficult airway from the history and the physical examination, and assuming that this patient is easy to ventilate, I would not do the awake fiber optic in this patient. Instead, I will proceed with the rapid sequence induction with cricoid pressure. Okay. So do you always do awake fiber optic when there's a history of difficult airway? There are other indications of awake fiber optic as well. But in this particular scenario, I don't see that the risks and the benefits of awake fiber optic outweigh the risks. Okay, what induction agent would you use? I would use ketamine. I take that back. I would use etomidate because etomidate is most cardiostable induction agent available in this patient who is already septic, has a significant mitral stenosis, and can suffer from dangerously low blood pressures during induction. Other agents such as propofol and ketamine and pentothal can drop the blood pressure in a patient who is sympathetically depleted. Okay, what about succinylcholine? Succinylcholine has a faster onset and offset, has a very predictable onset. I would use it as a muscle relaxant for rapid sequence induction, assuming that there are no contraindications to the succinylcholine that exist in the history. If airway is difficult to secure, is LMA acceptable? LMA is not my first choice in a full stomach patient because patient can aspirate. However, if I am not able to intubate this patient and there is a difficulty in oxygenating and ventilating this patient, that LMA does have a role. But LMA is a supraglottic airway, it's not a definitive airway, and it does not protect the airway from aspiration. Okay, assuming induction intubation is successful, is isoflurane suitable for maintenance? Isoflurane with oxygen and air is suitable for maintenance in this patient because I can titrate it easily by end tidal values, and it provides predictable amnesia. How about propofol infusion? Propofol infusion is also an acceptable choice. However, I am mindful of the fact that I cannot monitor the 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 plasma concentration of propofol or estimate the plasma concentration of propofol. So I will in addition use BIS monitor if I'm using propofol infusion. And also propofol is dependent on a patent IV access, and any kinking in the tubing or IV not in the right place can lead to inadequate or no delivery of propofol. And only way to know that is keeping an eye on the IV and the lining and the pump. Okay, so during the procedure AFib occurs with heart rate of 150. What is the danger? The danger of this high this high level of heart rate in a mitral stenosis is significant hypertension and also myocardial infarction. So, okay, so what would you do? I would put this patient on 100% oxygen, send a blood gas, correct reversible causes such as electrolyte and metabolic abnormalities and hypercarbia and so despite SpO2 of 100%, your oxygen saturation decreases from 98% to 85% over 15 minutes. Why do you think what has happened? I think most likely this patient has gone into fast AFib and then pulmonary edema has worsened. Congestive heart failure has worsened, and this patient is going into heart failure. How would you treat? I would DC cardiovert this patient. Okay, so now there's 10 minutes, but I had 2 questions left. I will just answer them. So, what are your other differentials? My other differential of drop in oxygen saturation is machine factors such as kinking of the tube, endobronchial intubation, mucus plug, then atelectasis, pulmonary embolism, and tension pneumothorax. So the PEEP decreases the blood pressure. Would you put any PEEP? I will titrate the PEEP until I have a best oxygenation and least effect on the blood pressure. Okay, so your end-tidal CO2 is 32, but PaCO2 is 48. What is cause of increased indifference? The gradient between end-tidal CO2 and PaCO2 is because of dead space. So most likely this patient has a dead space. That is area of the lung that is being ventilated but not perfused. This could be because of an embolic event. So you see, I was not perfect. I sometimes stumbled. I tried. I paused to think. Maybe I have not answered the questions correctly. But I tried my best. So let's move on to the post-op care for 15 minutes. And then we will try to analyze my performance. Let's go on to the post-op care. Assuming hemodynamic stability with pulmonary edema resolved, do you plan to extubate this patient at end of a surgery? Why not? My criteria for extubation is based on stability and a normal state of all the organ systems. If this patient is awake, alert, following commands, has a good respiratory function, that is, patient is breathing spontaneously with good negative inspiratory force and taking good tidal volumes, more than 6 cc per kilograms, has an adequate gas exchange, is hemodynamically stable, not requiring any pressors or inotropes, did not have any acute events during the surgery that might necessitate the prolonged intubation, and all anesthetic drugs are reversed, I would extubate this patient. However, in this particular patient, he has multiple comorbidities, that is severe mitral stenosis, and also has just recently gone through a major surgery and had a pulmonary edema episode intraoperatively. I will keep this patient intubated and transfer him to ICU and observe and for some time and then extubate this patient. What are you observing? So I will observe patients, I will get patients' labs, get patients' chest x-ray, and also slowly wean down the patient from a mechanical ventilation and observe if patient is maintaining the oxygenation and ventilation on progressively stepping down the ventilatory support. So what kind of ventilator support are you starting this patient on? Immediately post-op, I will start this patient on SIMV with pressure support. That will give patient the required minute ventilation required for oxygenation and ventilation, and also allow patient to trigger his or her own breath. And then next step is, if patient is triggering the own breath, I will change this mode to a pressure support ventilation, where patient can now trigger but get some additional ventilatory support to maintain the adequate tidal volumes. And slowly I will titrate the pressure support down, and then when patient's pressure support is minimal, I'll give patient a TPEACE trial, and then if other parameters of extubation are met, which I mentioned earlier, I will consider extubating this patient. Okay. So patient is now bucking and fighting on the ventilator. What are the reasons? So this patient can be light, might not be tolerating the tube or a ventilator, because ventilator my differentials are a light patient, and also patient may ventilator asynchrony, where ventilator is trying to deliver a breath, mandatory breath, and patient is trying to take his own breath, and then they're fighting for because they're opposite flows. The other reason can be that patient is trying to take a certain flow, but ventilator is set up at the flow which is less than the required flow. So patient can be having air hunger. So in any case, I would change this patient to a pressure support ventilation if patient is on a volume control ventilation. This will give patient adequate flow and also allow the patient to take or initiate own breath and try to prevent the opposite flow in asynchrony. And if patient is still coughing and bucking, patient might need more sedation. So I will deepen the sedation if patient is not ready for extubation. Why would you not paralyze this patient if patient is not deep enough? I'm not ruling out the paralysis at this stage, but if these steps do not resolve the problem, then I might consider it later on, because paralysis has its own problems. Paralysis impedes the weaning from the mechanical ventilation because it completely suppresses patient's own respiratory drive. So deepening of a sedation mostly can allow a patient to tolerate the endotracheal tube. Okay, so patient is awake and indicating pain. Is intramuscular morphine appropriate? There are better ways to deliver morphine, that is intravenous morphine, because it's more predictable, does not give sterile abscesses. I will use intravenous morphine. Okay. Is morphine your drug of choice for this patient? Again, I am mindful of the fact that this patient can have a renal impairment and morphine's metabolites are excreted renally. I will check the renal function of this patient, and if patient does have an acute kidney injury or a renal failure, then I would administer drugs that are not excreted renally, such as fentanyl. Okay, does controlled ventilation influence your choice? All the narcotics are respiratory depressants, and they can depress the respiration. So controlled ventilation takes away the clinical significance of that side effect. It might impede the weaning of a mechanical ventilation though, but I can safely administer narcotics if patient is controlled ventilated, but I'm aware of the fact that it will impede my weaning of a mechanical ventilation. How will you wean from the ventilator? So from weaning from the ventilator, I will start from SIMV as I explained earlier, go to pressure support ventilation with a PEEP, and then slowly wean down the pressure support. There's another aspect of weaning called weaning from FiO2. If this patient is requiring high FiO2, then I will also wean down the FiO2 slowly to ideally 30 to 40% before I consider extubating this patient. So the aspects of weaning include weaning from a mandatory ventilation to spontaneous breathing, weaning the pressure support or the support I'm giving, weaning the oxygen, and also weaning the PEEP. Okay, what if the patient is on PEEP? What's your extubation criteria? If patient is on PEEP, I cannot extubate the patient who is requiring a lot of PEEP for oxygenation, because after extubation patient will lose that PEEP and will desaturate. So I will slowly titrate the PEEP down and extubate the patient if patient is tolerating 5 centimeter water PEEP. Okay. With FiO2 of 0.4 and PO2 of 70 millimeter of mercury, PaCO2 of 45, pH of 7.33 during spontaneous ventilation, would you extubate this patient? Now, FiO2 of 0.4 and PO2 of 70 millimeter of mercury, I'll compare this with patient's baseline PO2 if I have. I do have a value of 50 millimeter of mercury pre-op, but I don't know if this is baseline PO2 or is it because patient had some heart failure, active heart failure going on during induction. I would try to guess patient's baseline PO2 or ABG if possible, or patient's baseline room air oxygen saturations. At this point, PO2 is 45. So if these values correspond to patient's baseline ABG, then I would extubate this patient, because this patient could have pre-existing gas exchange abnormalities, and the best I can get is this. Okay. However, if there's a deviation from significant deviation from the baseline, then I would not extubate this patient. Then I will also check clinically. I will look at the X-ray of the patient. I will make sure that patient meets other extubation criteria as I mentioned, that is CNS stability, CVS stability. Chest X-ray doesn't show any active pulmonary edema. My clinical examination doesn't show any rhonchi or any wheezing, and patient is comfortable, then certainly I will extubate this patient. So urine output is 0.5 kilogram per hour now. Is this adequate? This is a lower end of a normal urine output. How will you decide between fluid and diuretic? This decision is based on history, examination, and then some investigations. In history, I will look at what was the blood loss intraoperatively, what was the total fluid loss intraoperatively, what is the fluid running at, what rate is the fluid running at, and what has been the urine output. Has it been declining or has it been going up? Has it responded to the fluid boluses or not? And I will also assess patient's volume status. That is, does patient look dry, dehydrated based on the moisture on the mucous membranes, and also blood pressure and heart rate. If it's a low heart rate, tachycardic patient, is there a systolic volume variation on the A line? And if I have a PA catheter in place, what is the pulmonary capillary wedge pressure? What is the right atrial pressure? If based on all that, I think that patient is adequately hydrated, then I would give patient a small fluid bolus such as 250 cc's, that fluid challenge, and see the response to the urine output. If there's no response to the fluid challenge, and assumingly that patient's fluid status from my examination is euvolemia, then I would decide between a diuretic. However, I will also rule out any kinks or any obstruction in the Foley catheter first, and send out some investigations such as urine electrolytes and basic metabolic panel and serum electrolytes and blood gas, and then also urine analysis to see the casts, and then give a patient a diuretic. Diuretic is indicated in patients who are euvolemic or hypervolemic, and still oliguric. Okay. On postoperative day 3, patient is extubated and states that she was awake during the surgery. How is it possible? What will you tell her? If patient says she was awake during the surgery, I would there are multiple reasons that this can happen. The anesthetic reasons and the surgical reasons. The anesthetic reasons are inadequate anesthesia, and that can happen because of anesthesiologist's concern for hypotension in an unstable patient. So anesthesiologist might be delivering lower values of MAC, or this could be because patient might remember induction and extubation phases of anesthesia. I would talk to the patient, take a history, exactly ask what does patient remember, and document what my conversation with the patient. And then depending on what information does patient give me, I will provide her the answers. If patient is awake during intubation or induction, that's common because at this point patient will remember the events like putting a mask on, giving some supplemental oxygen, injecting the IV drugs. If patient says patient was awake during emergence, this is also possible because of patient will remember extubation, patient will remember uh, operating room conversations or me talking to the patient during extubation. However, uh, if patient remembers intraoperative events, that is after induction and before emergence, then I will have to exactly ascertain was it an explicit awareness or implicit awareness, was it bad dreams, was it specific events that patient remembers. So I would offer patient the counseling and try to explain what might have happened. Okay, on post-op day 4, patient becomes disoriented. What is an etiology? The acute delirium post-operative can be because of metabolic reasons, fluid and electrolyte disturbances, uh, hypoxia, hypercarbia, hypotension, hyperglycemia, drugs such as benzodiazepines, narcotics that can affect the central nervous system. It can also be because of brain edema if we're giving hypotonic fluids. And then it could be because of withdrawal from the analgesics. I will take a careful history about what drugs have been given and stopped. I'll look at the patient's drug chart and also look at the fluids that were given to the patient. And I will send a blood gas to look at the fluid electrolytes and the glucose and the metabolic status of the patient. I will try to correct at this point any hypoxia, any hypotension, and then I will approach the differential diagnosis in a stepwise manner by eliminating the reversible causes of delirium. If delirium still exists, then my priorities at this case are to keep patients safe and further investigate the reasons of the delirium.